Hi everyone! As part of the HELP series of high innovation surgical courses, in this video I'll be showing a 2-1 extraction with immediate placement of a Nobel Active implant and immediate temporization as well. So as we can see in the initial presentation, we look at the labial tissues, and luckily in this case it's around 0.5 mm or 1 mm higher than 1-1, and it's an ideal case for an immediate placement and immediate temporization as well. And the reason we want to do an immediate is to preserve the soft tissue architecture. So here is the initial 3D radiograph or CBCT, and we can see there's around 70 mm of length between the crest of the labial bone and the floor of the nasal floor. So it's quite enough amount of bone palatal and apical to the root for an immediate placement. The plan is to place a Nobel Active 3.5 narrow platform implant, and the aim is to place it palatal to the apex. A very common mistake is to start your initial drill on the apex or towards the apex, and then you end up with an implant protruding through the labial bone. We're aiming for the axis screw hole to be on the palatal side of the tooth, just to allow for a screw retained abutment or a screw retained crown, or at least an angulated screw channel crown. We have sufficient amount of bone labial-palatally for this case, and to me it looks like an ideal straightforward case for an immediate placement. The initial drilling should be between the apex and the palatal wall, a little bit midway of the root. And the good thing about the Nobel Active is sometimes you can reverse and change the direction slightly during insertion. So we're trying to do an atraumatic extraction. There are different ways of doing that. My preference is using some peritomes, and with a small mallet, just very gentle tapping, and this just widening the periodontal ligament space between the root and the bone. So very gently applying a little bit of tapping on the mesial corner and the mesiolabial corner, and the distolabial and the palatal, and on the distopalatal and mesiopalatal. There are different sizes for those peritomes. Sometimes I start with the thinnest one, then slowly work to the thicker one. And just taking your time, there's no rush. The more time you spend on the extraction, the less complications you have when dealing with the soft tissues. And the idea here is to preserve the architecture of the papillas and avoid any trauma to the papillas as well. So working out with a larger peritome, with a bit of tapping as well. I apologize for the quality of the video. That's one of my first videos that I recorded with a head-mounted camera, and we didn't know how to adjust the lighting properly at this stage, so that's why there's few lines, but we're working to improve that at this stage. So various narrow small luxator just to get a feel of the root, and I believe the composite will just come off at this stage because it's very weakly bonded. And if you notice, I opened the contact first with my handpiece before I start the extraction, just to allow some space for the root to move on the mesial and distal direction. And luckily, as we know, the upper center incisors, the roots are conical, so it's very easy to just hold them at the end, and with a small twist it should come out very straightforward. Here's the composite coming off, and here's the root very gently coming off. As I said, there are different ways of atraumatic extraction, and it all comes to what are you comfortable with and which way you're happy with. Some people might section and leave a small labial part of the root on the labial bone. So it's very slight curettage just to remove any remaining tissues on the bone, and getting a feel of the labial plate as well. And here is the initial drill, and with the Nobel system we're using a precision drill. In this case, I rarely use loops or magnification when I'm placing implants, and because of the camera that's mounted on my loops, I had to use my loops. So I wasn't very comfortable with my drilling because the visibility is different when it's magnified. So my initial drill will be off, and then I'll correct it after the second drill. It's a very simple case. We're not using any guides. We are not using any pre-made surgical guides. But again, it's not like I recommend not using guides or using guides. It all comes to your clinical preference. So my drill was my initial drilling was a little bit too high in this stage. And always take a radiograph to check your initial drill. If it's going off mesially or distally, you can correct it easily at the beginning of the drilling. It's a very common mistake to start placing an implant without taking an initial radiograph. And we've seen cases where an implant is directing itself towards the root or towards damaging other tooth structure next to it. So here I'm just correcting my drilling. So I'm going to start another initial osteotomy just apical to the first one, because the first one was too high. So you can see the direction of the initial drilling is, you might get a feel that the drill is going too labially, but then you will correct it with the second and third drill, and then you'll correct it with the, when you place the implant, you can change the direction slightly while placing the implant. The precision drill has a very sharp end. Some people prefer to use a small round burr. And here you can see on the palatal wall the direction of the initial osteotomy. And now with the Nobel Active in the kit, it gives you a sequence of the twist drills with different sizes. And it depends on if you have a soft bone or a medium bone or a hard bone. So in this case, we're only using another twist drill, which has a 2 mm diameter. You've got a large gap on the labial or labially to the drill. So you're always aiming to put pressure on the palatal side to avoid the drill from running labially. So you can see my finger rests on the other teeth, my finger support on the head of the handpiece as well. You have to control your drill because it always wants to run towards the gap. So we're measuring around 15 mm from the palatal crestal bone because we're aiming to place a 15 mm implant. So because I'm using my loops, I had to use an indirect vision to place my drill, which usually without loops I can bend down and just have a direct look before placing the first drills. But again, it's a little bit outside my comfort zone, but I thought for the sake of recording, I will try something different. So again, very good finger support on the teeth, on the neighboring teeth, and very good finger rest on the head of the handpiece, just to avoid the drill from running anywhere towards the gap. So now we're using a 2.4 to 2.8 diameter drill, twist drill, and the same thing, always putting more pressure towards the palatal wall to avoid the drill from running to the labial. You can see the place or the level of the osteotomy there on the palatal wall. So we're using the 3.5 times 15 Nobel Active implant. So you can see it's just minimal drilling. The idea of Nobel Active, you want to make your osteotomy a little bit smaller than the implant itself. We're trying to achieve 60 to 70 Nm initial torque to allow for immediate loading. The minimum required is 35 Nm. So just trying to avoid the apex and getting into the osteotomy first. Always use a hand driver when dealing in this area or whenever accessible. The reason is under the osteotomy you have the nasal floor, and I've seen a mistake where you can forget to adjust your motor, and then when you're placing the implant, you're placing on 1000 RPM, and then the implant in 1 second go into the nasal floor. So always use a hand driver. You can get a feel of the bone, you have a lot of control, and of course you can avoid any unwanted encroachment to vital structures. So very gently just placing in, just having a look on the location of the implant. So with Nobel Active you can always reverse and then place again, and this with small reverse you can change the direction slightly. So now checking the torque range, so we are achieving around 60 or 70, and here's the location of the implant, and you can see it's palatal to the labial plate. You need to have a small gap between the implant and the labial bone, and that's why we choose the narrow platform, to allow enough space to graft this gap and give as much support as we can to soft tissue. I'm very happy with the location of this implant. Maybe it was, if it was just slightly labial, I would be a bit happier. So now we're gonna do the temporary. We're gonna use a temporary abutment. And what I do is I cut a very small piece of sterile glove fingertip and we're gonna make a very small hole in it. And the idea of this little piece of latex is just to provide a good emergence profile for the crown, and you can do a direct composite temporary and also avoid the blood from the osteotomy from getting into your composite. So here's a temporary abutment. It has different measurements. There's a 1.5 and 3 millimeter height. So you always measure between the implant platform and the papilla as well. Here, checking the occlusion, making sure there's no, it's not touching on any centric or eccentric movements. I will do some adjustments at the end to the abutment as well. Different screws on dealing with the gap in front of the implant. Some screws just place bios, some place bios with different other organic matters. Some people use leave a small dentine bridge attached to the labial plate. As I said, that's my clinical preference, and I'm open to any different ideas. Sometimes I try different things, but in this case, I decided to place bios with some blood on the labial gap. So here we have the index that we took preoperatively. This patient walked in on the day, so we didn't have models or anything. We just basically walked in, placed the implant, took an index first, and we're gonna place a direct composite temporary. So here's the latex. It's just protecting the socket, and we're using Genial Universal Flow A2 just to place the palatal wall and the proximal walls. This is just a very quick composite, nothing fancy, nothing, no layering techniques or anything. And the most important thing, it should be out of occlusion on all centric and lateral excursions. And of course, after placing the composite, we're gonna remove this temporary and repolish all of the fitting surface between the tissues and the temporary. So we can have a highly polished tissue surface to allow proper flossing. Also, you need to have very light or nearly no proximal contacts to allow flossing without any early loading on the implant. The first 3 months, we want to avoid any extra loading on the implant to avoid any failures. Just adjusting my latex metrics. So place it more genial towards the labial emergence profile. I think the whole appointment from start to finish took around 60 minutes or 80 minutes between this time. And here's the final layer of Estelite enamel shade. Just using my finger. As I said, nothing fancy at this stage. We just want to make a quick, functional, good looking temporary, but not perfect, of course. Because you can finish all of this outside the mouth after you finish. We're using the tiniest amount of temporary cement. At the end, you just, with your Explorer, just paint very gently on the labial fitting surface and the palatal fitting surface, and make sure you don't have any temporary extruding from the temporary when it's placed on the abutment. And here's the final radiograph, and as we can see, the implant has a good position. We have enough bone mesial and distal to the implant. It's has a bicortical support from the nasal floor, and here's a photo 10 days follow-up. You can see very good soft tissue contour. The temporary is shorter than the 1-1. Thank you for watching, and please like and share the video if you find it useful. And if you have any interest in our implant courses, please visit our website. Thank you very much.